Imagine this. You wake up on a random Tuesday, you go about your normal morning routine, maybe, pour a cup of coffee, check your phone, and suddenly you get a headache.
Right, just a totally normal day.
Exactly. It's annoying, sure, but you figure it will pass. So you take an ibuprofen, you drink a glass of water. But it doesn't pass. In fact, that exact same headache stays with you through Wednesday, into Thursday, into next month, and then for the next 5 years, it simply never goes away.
Wow, yeah. It sounds like a terrifying hypothetical, but for a really specific subset of chronic pain patients, it is their daily, unremitting reality.
Welcome to the Deep Dive. Today, we are on a mission for you, the listener, to explore a massive paradigm shift in how we understand and treat chronic, never-ending head pain.
And we've got a really fascinating stack of sources today. We are pulling from clinical materials from the Migraine Surgery Specialty Center, an in-depth clinical resource guide on a condition called New Daily Persistent Headache, or NDPH, and a highly specific medical anatomy and pronunciation guide.
Right. And our focus for this conversation is tracing a very specific and honestly highly unconventional medical journey. We're going to look at how a board-certified plastic surgeon, Dr. Adam Lowenstein, is using outpatient nerve decompression surgery to treat this unremitting headache.
Yeah, he's specifically targeting patients in the Los Angeles area and beyond who have successfully responded to a diagnostic nerve block.
Which is so interesting because we're looking at a structural, physical cure for what has historically been viewed as an invisible chemical disease.
Totally.
But before we get into surgeons and nerve blocks, we have to understand the villain of our story. So what exactly is this never-ending headache? Because reading the sources, NDPH seems to break all the normal rules of how we think about pain.
It really does. So NDPH stands for New Daily Persistent Headache. And what makes it so unique and frankly so jarring in the clinical landscape is its hallmark feature, which is a sudden, vividly memorable onset.
Really memorable.
Yeah. Like if you talk to someone with chronic migraines, they will usually tell you, oh, their headaches started in their teens, happened maybe once a month, and just gradually worsened over decades.
Right.
But an NDPH patient can tell you the exact day, and sometimes the exact hour, their nightmare began.
The sources mention this onset often happens right after a viral illness or like a highly stressful life event or even just a minor medical procedure. And then it just sets in. But how does a virus or a bad week at work trigger a headache that lasts for years?
Well, the initial trigger, whether it's an immune response to a virus or severe stress, it often causes a massive spike in systemic inflammation or intense sustained muscle tension.
Oh, okay.
So that initial insult creates a physical tightening in the tissues of the head and neck.
Yeah.
And even after the virus clears or the stress subsides, that tissue remains locked down.
Wow. And the International Classification of Headache Disorders, the ICHD-3, they have very specific criteria for this diagnosis, right?
They do, yeah.
The headache must be present for more than 3 months. It must be daily and unremitting from the very onset, or at least within 3 days of that onset. And the patient has to distinctly recall that start date.
Exactly.
But reading through the clinical guides, the actual symptoms seem completely all over the map.
And that is the crux of the diagnostic trap. The criteria dictate the timing of the pain, but they don't really describe what the pain actually feels like.
Yeah.
For some people, it is a throbbing, pulsing pressure. For others, it's a stabbing or burning sensation. And it routinely comes with all the classic migraine accessories, severe brain fog, debilitating light sensitivity, sound sensitivity, nausea.
Because the symptoms are so broad and there is no blood test or brain scan that shows a glowing red spot saying, hey, here's the NDPH, it seems like patients are just thrown into a diagnostic blender.
Oh, absolutely.
The sources say patients often carry 3 different diagnoses simultaneously, or they have their label changed year after year by different doctors.
Yeah, because headache medicine relies almost entirely on patient-reported symptoms. It is a diagnosis of exclusion, meaning a physician has to rule out tumors, aneurysms, other acute dangers first.
Right, make sure it's not going to kill you.
Exactly.
Yeah.
But once those are cleared, patients find themselves lost in muddy waters because NDPH overlaps so heavily with chronic migraine or chronic tension type headaches.
Oh, I can't even imagine.
The psychological toll of that is immense. You have a patient in daily agony, and the medical establishment can't even agree on what to call their pain.
Okay, I have to play devil's advocate here for a second, though.
Sure.
If I'm the patient and my headache looks like a chronic migraine, acts like a chronic migraine, has the horrible light sensitivity of a chronic migraine, Why does the specific NDPH label even matter? Aren't we just splitting hairs over medical terminology? I mean, the name doesn't change the pain I'm feeling.
It's a fair question, but the label matters entirely because the label dictates the treatment pipeline. Standard neurology operates on a very specific workflow. If a doctor labels your pain as a purely central neurological issue, meaning a malfunction in the brain's processing, they're going to treat the chemistry of your brain,
So they throw pills at it.
pretty much.
Mm.
Patients spend years, sometimes decades, trapped in a cycle of failing medication trials.
Wow.
They cycle through standard preventive agents. They prescribe things like topiramate, which is actually an anti-seizure medication used off-label to try and slow down the electrical signals in the brain. They're given beta blockers, which are blood pressure drugs. They even try the newer CGRP antagonists.
Wait, what is a CGRP antagonist? That sounds incredibly intense.
It is, yeah. CGRP is a specific protein in the brain that transmits pain signals. The newer antagonist drugs are designed to essentially block that protein.
Gotcha.
But the underlying philosophy of all these drugs is the same. Standard neurology focuses almost strictly on the idea that the brain's pain pathways have just become hypersensitive. They are treating the software of the brain.
Treating the software. But what if the software is fine and the hardware is broken?
Exactly.
Because NDPH is defined purely by its timing, that sudden onset, and not by its actual physical mechanism, it leaves this massive blind spot in patient care. Like, we are looking for a chemical imbalance when the problem might be a physical roadblock.
And that blind spot is profound. I mean, for half a century, medical textbooks explicitly taught that migraines and chronic headaches were strictly vascular, meaning blood vessels expanding inside the skull, or purely neurochemical.
Right.
Generations of neurologists were trained to actively ignore the muscular anatomy on the outside of the skull.
Which brings us to the anatomical epiphany in these sources. This is where Dr. Adam Lowenstein and a radically different paradigm come into the picture.
Yes.
Instead of assuming the brain is just malfunctioning on its own, this approach looks for a physical structure outside the brain that is constantly sending a pain signal inwards.
Right, taking a mechanical approach to a seemingly invisible neurological disease, which completely rewrites the treatment options.
Let me try an analogy here to help visualize this, because reading the anatomy guide, this is the image that popped into my head.
Go for it.
Imagine you have a garden hose, and the water is barely trickling out because there is a heavy rock sitting right on top of a kink in the hose.
Okay.
Standard headache medicine is basically pouring different chemicals into the water supply, hoping to magically fix the flow. But Dr. Lowenstein's approach is, hey, why don't we just move the rock?
I love that. And taking that analogy a step further, in the human body, the hose is a peripheral sensory nerve. These are the nerves that give your face and scalp the ability to feel touch, temperature, pain.
Right.
And the rock is usually a tight muscle, a band of dense connective tissue called fascia, or an intersecting blood vessel that is physically strangling that nerve.
The anatomy guide goes incredibly deep into the specific locations where this happens, but there isn't much room between the skin and the skull, so where exactly are these nerves getting trapped?
Well, the sensory nerves of the face, scalp, and neck don't just float in empty space. They have to weave through complex layers of muscle and tissue to reach the skin.
Okay.
And at certain anatomical bottlenecks, they are highly vulnerable to entrapment. A prime example, frontal region above the eyes.
So what is physically happening above the eyes to cause a daily headache?
You have two major nerves there, the supraorbital nerve and the supratrochlear nerve. They emerge from the skull just above your eyebrow and have to travel straight up through a muscle called the corrugator supercilii.
I am going to need a translation on corrugator supercilii.
Oh, right. It is the frowning muscle, the muscle that pulls your eyebrows together when you concentrate, squint, or get angry.
Oh, okay.
If someone is constantly stressed or dealing with the initial tissue tightening from a viral onset, that muscle becomes hypertrophied. It actually grows thicker and more rigid, much like a bodybuilder's bicep, but right over your eye.
Okay.
Yeah, and that thickened muscle literally pinches the nerves passing through it. The patient experiences this as a constant crushing frontal headache.
That seems awful. The sources also detail Site 4, which is at the back of the head, the occipital region. What's the trap there?
So in the back of the neck, you have the greater occipital nerve. It has to pierce through a series of very heavy, dense neck muscles, specifically one called the semispinalis capitis.
Okay.
If you have a history of whiplash, poor posture, or chronically tight neck muscles, that nerve gets squeezed relentlessly against the fascia.
This actually leads to a fact from the sources that totally blew my mind. It's this counterintuitive cross-reference of pain. You can have a pinched occipital nerve at the very back of your neck, but you feel the blinding pain at your temples or right behind your eyes.
Yep.
How does a pinch in the back of the neck make my forehead hurt? That feels like faulty wiring.
It really seems like a biological error, but there is an elegant anatomical explanation. All of these peripheral nerves, from the face and the back of the head, they don't have separate dedicated pathways straight to the conscious brain.
Right.
They all eventually report back to the exact same central pain processing relay station in the brainstem. It is a structure called the trigeminal nucleus caudalis.
So it's like a central switchboard for the whole head.
Precisely. When that switchboard gets flooded with intense pain signals from a trapped nerve in the back of the head, the brain gets confused about exactly where the alarm is coming from.
Oh, that makes sense.
So it often refers the pain forward to the eyes or the temples. A patient might sit in a neurologist's office swearing they have a frontal migraine, but the actual rock on the hose is buried deep in the back of their neck.
And this perfectly explains the mechanism of constant pain. The sources talk about this concept of central sensitization. If that nerve is constantly getting pinched by a heavy neck muscle, it's not like an inflamed knee that only hurts when you put weight on it.
No, not at all. And when a peripheral nerve irritates the brainstem for long enough, the central nervous system physically changes. Its threshold for pain drops, the system becomes sensitized.
So that low-level, constant physical pinch gets amplified by the hypersensitive brain into a roaring, unremitting headache.
Yes. Suddenly, the exact clinical presentation of NDPH, a constant, unwavering daily headache that started after a stressful event, is perfectly mimicked by a pinched nerve.
Wow.
For some patients, what has been labeled as an untreatable mysterious brain disease is actually just a peripheral nerve getting crushed by a tight muscle.
The implications of that misclassification are huge. It means the pain generator is localized, physical, and potentially removable.
Yes.
But if the switch is buried under a heavy neck muscle or an overgrown frowning muscle, how do we find it without just cutting someone open and hoping for the best? Because we can't see the pinched nerve on an MRI, right?
Right, you can't see it on an MRI. So we find it using one of the most vital yet frustratingly underutilized investigative tools in headache medicine, the diagnostic nerve block.
I love this part of the deep dive because it is so incredibly elegant. It's a real-time physical test. Walk us through how this proves the hardware is broken.
So a physician takes a very small volume of local anesthetic, sometimes mixed with a little steroid, to reduce local inflammation, and injects it directly into the anatomical location of the suspected trigger point.
Okay.
They are injecting it right into that frowning muscle or directly over the heavy neck muscles in the back.
I know. You're literally hitting the nerve with numbing medicine.
Yes. And the question we are asking is very simple. Does the patient's headache improve?
Right.
Even if it is just temporary relief for a few hours, a positive response provides objective physical evidence that that specific peripheral nerve is contributing to the headache. It isolates the pain generator in a way that listening to a patient describe their symptoms never could.
It's a physical off switch. If you numb the nerve in the neck and the decades-long headache in the forehead suddenly pauses, you found the rock on the hose, it definitively proves it's not just a chemical imbalance in the brain.
Exactly. The diagnostic power of that temporary block is profound because it predicts surgical success. If a nerve block turns off the pain temporarily, surgically removing the physical compression on that exact same nerve is highly likely to turn it off permanently.
The sources also mention Botox as an alternative diagnostic tool. How does that compare to a nerve block?
Well, a 3-month course of botulinum toxin Botox injected into these specific trigger sites can serve a similar function.
Okay.
Instead of just numbing the nerve, the Botox temporarily paralyzes the muscle that is doing the pinching. It releases the compression and gives the patient and doctor longer duration feedback.
Got it.
But the clinical data shows that a positive response to a simple in-office nerve block, combined with careful mapping of where the pain starts, is often entirely sufficient to establish that someone is a candidate for surgery.
But here is the massive frustrating gap in care highlighted in the sources. Most NDPH patients who have been suffering for years are never even offered this simple test. Why aren't neurologists doing this on day one?
It goes back to those medical silos we discussed. The neurologists managing chronic headaches are brilliant at neurochemistry, but they are not trained in surgical anatomy.
Right.
They don't routinely palpate the skull, looking for tight fascial bands or overgrown muscles. If standard neurologists do use occipital nerve blocks, they usually frame it as a palliative measure, basically a way to give the patient a few days of temporary relief.
So they treat it like a really strong aspirin, like a Band-Aid.
Exactly. It is rarely framed as a diagnostic step toward a permanent cure. The conceptual bridge between this injection helped and therefore surgery could cure you exists almost exclusively in the minds of headache surgeons, not standard headache neurologists.
Let's say a patient, maybe someone listening right now in the Los Angeles area, pushes for that nerve block. They get the injection, and for the first time in 5 years, the alarm bell stops ringing. They have that profound aha moment.
Yeah.
Now they need an expert to permanently remove the physical roadblock. This is where Dr. Adam Lowenstein comes in.
Dr. Lowenstein is uniquely positioned to bridge this gap. He is a highly experienced, board-certified plastic surgeon. He understands the microscopic anatomy of the face and neck, but his dedication to this specific cutting-edge subspecialty of headache surgery comes from a very personal place.
Right. He was a patient himself.
Yeah, he suffered from severe, debilitating migraines himself for over 20 years.
So he knows the despair of the chronic pain cycle from the inside out. He built his migraine surgery specialty center from the ground up to address this exact gap in care.
Exactly.
Say I'm a patient in LA. What does this surgery actually look like? Are they opening up my skull?
That is a very common fear. But no, they are not opening the skull. This is an outpatient procedure.
Okay, good.
It is performed under general anesthesia, but the surgeon is working entirely on the outside of the skull, just beneath the skin and within the superficial muscle layers.
Hold on, I have to stop you there and push back because this sounds almost too good to be true. You are telling me a patient who has been in daily agony for 15 years, taking heavy anti-seizure meds, having their life ruined by pain, can just get a quick outpatient procedure and be cured? Where is the catch? Where is the hard data proving this works?
The skepticism is absolutely warranted, and it is exactly why the foundational research in this field was so rigorously designed. Dr. Baman Gayron, the plastic surgeon who pioneered this entire field in the early 2000s, conducted a gold standard sham-controlled randomized trial to prove it wasn't just a placebo effect.
Wait, a sham surgery? They actually put people under and did fake surgeries?
Yes. In the control group, the surgeons made the incisions but deliberately did not release the trapped nerves. In the actual treatment group, they removed the compressive tissues. And the results were undeniable. He found an 83.7% success rate in the real surgical group, with over half the patients achieving complete 100% elimination of their headaches.
That's incredible.
And the sham group showed no such long-term improvement. Dr. Lowenstein's own personal clinical series boasts a 93% improvement rate in appropriately selected patients.
93% improvement for a patient population that has failed every drug on the market. That's huge. How does Dr. Lowenstein actually perform the release during the outpatient procedure?
Well, depending on where the positive nerve blocks indicated the trigger points are, Dr. Lowenstein makes very small incisions. For frontal headaches, these are often hidden entirely in the natural creases of the upper eyelid or behind the hairline.
Oh, nice.
He accesses the trapped nerves and carefully cuts away the restrictive muscle fibers, the tight fascial bands, or ligates the blood vessels that are actively strangling the nerve. He permanently releases the compression.
He moves the rock off the hose forever. And the recovery from an outpatient procedure like this?
It is generally very well tolerated. Most patients are back to normal light activities within 1 to 2 weeks, with the tiny incisions fading rapidly.
To put a human face on these incredible numbers, the sources include a testimonial from a patient named Sona K. Her story is wild. She had suffered from severe daily migraines for 15 years. 15 years of her life hijacked?
Yeah, it's heartbreaking.
No preventative drugs worked. No abortive therapies worked. She was so desperate she literally traveled from Slovakia in Europe all the way to California to see Dr. Lowenstein.
And Sona's outcome is a reality that standard neurology often tells patients doesn't exist. 3 months post-surgery, she reported that her life had changed completely. She found complete relief and called Dr. Lowenstein a lifesaver. And outpatient surgery gave a woman her life back after a decade and a half of suffering.
It's amazing. But Sona's story perfectly illustrates what is referred to as the candidate gap. Sona was the perfect candidate for this. She had constant pain, she had failed medication trials, and she had tender trigger points on her anatomy.
Right.
Yet patients exactly like her, especially those carrying the NDPH label, are the least likely to be referred for this surgery by standard neurologists.
The candidate gap is a tragedy of misclassification. If your primary doctor or neurologist does not fundamentally believe a headache can be caused by a structural problem outside the skull, They will never look for one.
They won't even think to check.
Exactly. They won't feel the muscles in your neck.
Yeah.
And you will never be offered the simple nerve block that could prove it.
As we synthesize this deep dive for you, the listener, the takeaway is clear. If you or someone you love is suffering from an invisible, unremitting headache, whether a doctor has labeled it NDPH, chronic migraine, or chronic tension headache, you need to know that there is a tangible anatomical frontier out there.
Absolutely.
The pain might not just be a chemical ghost in the machine, it might be a physical entrapment.
And your most important actionable step is empowerment. You have the right to ask your physician about diagnostic nerve blocks at your specific pain trigger points.
Yes, advocate for yourself.
Understanding the profound difference between a chemical problem and a structural problem allows you to advocate for better healthcare. If a nerve block provides even temporary relief, it is a glaring green light that a consultation with a specialized headache surgeon like Dr. Lowenstein is the appropriate next step.
You do not have to just accept a lifetime of pills and "we don't know" as an answer.
Because knowledge is only truly valuable when it is applied to change outcomes. Today's deep dive is about applying a completely new mechanical lens to chronic pain.
Which leaves me with one final lingering question, a thought to mull over as you go about your day. If a debilitating, severe, decades-long neurological headache can be entirely cured by simply unpinching a nerve hidden in the forehead or the back of the neck, what other invisible chronic pain conditions in the human body are actually just structural mechanical problems secretly waiting for a surgeon to find the right switch? Think about that next time you wake up on a Tuesday.